Enzo. Thank you for this very generous invitation. It is always a huge pleasure to be at SIXO. In light of our previous discussion about the health economics, I want to share with you a study I'm currently undertaking and acknowledge the help of many in my organization, including the funding from both the Department of Surgery and Women's Auxiliary in making this possible. I think by now we all know that the human endothelial cells do not replicate in vivo in humans. This is the result of cell-cell contact inhibition and the fact that the endothelium are arrested in the G1 phase, so we have a defined endothelial cell density. Fuchs dystrophy has now become the most common cause of corneal transplantation in the United States, and we know that in these patients, the guttae appear centrally and then later in the disease present in the paracentral cornea. Women are involved more than men, and in a subset of patients, the guttata are confined to the central cornea. We also, I think, are very aware that in corneal transplantation, the risk of rejection is greater in full thickness than in EK. We avoid rejection with the use of topical steroids, but if you stop the steroids, Price et al. Has shown that even in DMEC, the risk of rejection increases to 6%. That's 1 in 20 patients. And steroids increase the risk of glaucoma and cataracts in our patients. So Decimase stripping only was well described and shown to us by Dr. Colby yesterday. This is really something that came out of an accidental report back in 2003, and most recently has been described in the literature by Borkar, Maloney, and Pineda. So recently, last year, Dr. Maloney did a series of Decimase stripping only. 2 patients failed to clear, and he initially treated them with a rho kinase inhibitor from Dr. Kinoshita, and then found a commercially available rho kinase inhibitor, and by treating the patients who failed to clear, they cleared quickly. And it's not really clear if the peripheral endothelium repopulated the denuded area by spreading or replicating. So the rho kinase inhibitors have been demonstrated in monkeys, rabbits, and now in humans to result in proliferation of the corneal endothelial cells and are shown to work through topical application. In Japan, Kawa has a commercially available rho kinase inhibitor called Ripacidil, seen in your lower right. This was approved by their FDA in 2014 and is used solely for the purpose of the treatment of glaucoma. Recently in the United States, a ROCK2 inhibitor from Aerie was also approved. So with this in mind, the hypothesis of my study is that primary Decimase stripping only with or without endothelial keratoplasty and Fuchs dystrophy will heal faster with a higher final endothelial cell count when patients are placed on topical rho kinase inhibitor drops in the immediate postoperative period. This study's been done with the permission of the FDA in the United States with an IND, as you see here, and is registered on clinicaltrials.gov. The inclusion criteria were very strict for this study. Patients with Fuchs dystrophy limited to with guttata limited to the central 5 millimeters of the cornea, with a clear peripheral cornea with an endothelial cell count of greater than 1,000 cells per squared millimeter. The patients needed to have a visual disturbance as evidenced by morning blur or central corneal edema with a pachymetry of greater than 680 centrally, best corrected visual acuity worse than 20/50, and no visible subepithelial haze that could interfere with postoperative visual recovery. 18 eyes of 18 patients were enrolled to date with 12 months follow-up. 9 underwent Descemet stripping only, with or without cataract extraction, and were treated with observation with postoperative medications of antibiotics, steroids, and sodium chloride 5% ointment at bedtime. 9 underwent primary Descemet stripping only with or without cataract surgery and were started on Rapacidol drops beginning postoperative day 1 in addition to the above regimen. Our primary outcome measures were a comparison of pachymetry pre to post, weeks to visual acuity of 20/40 or better, endothelial cell counts, and complications. Here's a patient with classic central Fuchs dystrophy. As you can see, the central cornea is edematous, the periphery is not. Now, how do we strip the Descemets? Come on, play. So this is an example right there, let's see if I can stop it, of poor Descemet stripping, where the upside-down Sinskey hook actually is embedded in the stroma, and you see that jumping of the cornea. When this happens, as you see there, and let's just go all the way to the end, you see this white posterior stromal haze. But it's not the end of the world if it's not in the visual axis, because these patients will still recover good endothelial cell counts. Here, I'd like to demonstrate for you my preferred stripping technique using the irrigation aspiration handpiece, where we're simply performing a descemetorrhexis in the same manner that we perform a capsulorhexis with slow tearing and the Descemets folded over on itself to result in a nice circular, smooth-edged tear of the Descemet's membrane. And I think that Dr. Pineda has shown to us how important this can be for healing. So immediately post-operatively, these patients don't look so good. Their cornea is quite swollen, and it's best you warn them. But post-stripping, the corneas do clear, as you see here, and they clear very well. The difference here, pre-operatively and post-operatively. So let's look at some of the endothelial cell counts. This is the peripheral endothelial cell count of a patient. Here's the patient at 3 months, where we see these very interesting hyperreflective nuclei, and here at 12 months post-op. And here is a patient treated with Rapacidol, the peripheral pre-op, 3 months, oops, let's go back, 3 months, 6 months, and at 12 months. Our findings demonstrated that 13 patients complained of redness, 3 of stinging. 1 of our male patients was totally intolerant to the Rapacidol, developing severe abdominal pain and constipation. This patient was moved to the observation group, hence we had 10 patients observed and 8 treated. Our results looking at the pachymetry observation group versus rho kinase group were not statistically significantly different. Looking at the weeks to 20/40 or better vision, the rho kinase group healed much quicker. They recovered their vision more quickly. This was statistically significantly different with a paired t-test. Looking at the results of the endothelial cell counts peripherally from preoperatively to 1 year post-op, it's quite interesting that in the observation group, the peripheral cell count did decrease approximately 10%, where it was approximately the same in the rho kinase group. The central endothelial cell counts at 1 year were significantly higher in the rho kinase group versus the observation group, again statistically significant. In the Rapacidol group, all patients were clear at 6 months. However, One patient developed diffuse corneal edema at their 1-year postoperative visit. This was quite shocking, and I thought this was endotheliitis, treated the patient with topical steroids and oral antivirals, hoping the patient would recover. But in fact, there was no change, and after 3 months of persistent edema, the patient underwent successful DMAC and was deemed a failure. So at 6 months, it looked like all the patients cleared on the rho kinase, but at 1 year, one of the patients had failed. So in conclusion, in the observation group, one of the patients was a slow responder and actually took 6 months to clear. In the Repassidol group, all patients were clear at 6 months, but one failed at 1 year. All the patients cleared, but the patients on Repassidol cleared faster with a higher endothelial cell count. One patient was intolerant to Repassidol, and in the observation group, we noted approximately a 10% decrease in the peripheral endothelial cell count, while not in the Repassidol group. And this may suggest that the cells are reproducing versus simply spreading out to cover the area of denuded decimase. So what's next? Well, who's the ideal patient? I don't think this is for every Fuchs dystrophy patient. Our inclusion criteria were very strict. We're expanding them slightly at this time. We're now embarking on a second study to look at the ideal dosage. We're not sure if the endothelium are replicating or spreading. We do know that topical Repassidol does appear to work. And the question is, do we still need corneal donor tissue? Maybe not in some patients. And this may be from a socioeconomic perspective, a good improvement for our patients, as it costs us for this study $67 for one bottle of Repassidol. So thank you so much for your attention.